Welcome to Oncology Data Advisor. I'm Kira Smith. Today I'm joined by Dr. Ticiana Leal. Last year, Dr. Leal chaired a CME NCPD activity focused on immunotherapy-based strategies for advanced non-small cell lung cancer. Today, she will be sharing the updates that have occurred in the field since recording this activity. So thanks so much for joining today, Dr. Leal. To start off, would you like to introduce yourself and tell us about what you do?
Hi, I'm Dr. Ticiana Leal. I'm a thoracic medical oncologist at Emory University in Atlanta, Georgia. I'm an associate professor of medicine and director of a thoracic medical oncology program. I mainly see patients with thoracic malignancies in clinical practice and also conduct clinical trials from phase 1 to phase 3.
Great. So what are some of the new developments in immunotherapy for advanced NSCLC that have occurred since this activity was recorded last March?
The field of thoracic oncology is moving quite rapidly. And even since we last recorded our podcast and a video of advances in immunotherapy in non-small cell lung cancer, we've had new approvals of therapies in the front line for patients with advanced non-small cell lung cancer. For example, we now have approval of a regimen called the Poseidon regimen, which led to the approval of the combination of chemotherapy with immunotherapy with a PD-L1 inhibitor called durvalumab in combination with a CTLA-4 inhibitor, tremelimumab, in patients with advanced non-small cell lung cancer whose tumors do not harbor an EGFR or ALK alteration. So another strategy in the front line using a CTLA-4 inhibitor for patients with advanced non-small cell lung cancer. We've also had approval of another agent in combination with chemotherapy, cemiplimab. Cemiplimab was previously approved as monotherapy, and now we have approval of cemiplimab, a PD-L1 inhibitor in combination with platinum-based chemotherapy for advanced non-small cell lung cancer in the frontline setting. Based on our last presentation, I had discussed the excitement around tiragolumab, an anti-TIGIT antibody used in frontline in combination with atezolizumab. We had some really promising data based on the Cityscape, which was a phase 2 trial really demonstrating some promising results in patients with PD-L1 high expression. Since then, we've had readout of one of the co-primary endpoints of the Skyscraper-1 trial, which actually demonstrated that the combination of tiragolumab with atezolizumab in patients with high PD-L1 tumor expression did not meet the co-primary endpoint of progression-free survival. However, we're still waiting on the readout of overall survival, and tiragolumab, or anti-TIGIT, is still in development for advanced non-small cell lung cancer. Lastly, another interesting development that has occurred, we talked about some promising strategies in second line, looking at how to overcome immunotherapy resistance for patients with advanced non-small cell lung cancer, and talked about the VEGF pathway as a potential interesting pathway to target in combination with immunotherapy. We saw the results of a study presented at ASCO 2022, as well as now published in the JCO, investigating the combination of pembrolizumab with ramucirumab, hitting VEGF as a target there to overcome resistance to IO, and saw that that was a positive study in a randomized phase 2 setting, demonstrating improved overall survival. And so that is a really promising strategy that is moving forward in the phase 3 now. We have an ongoing, talking about future trials, Pragmatica, as the next step to really confirm these results. Pragmatica is a study investigating the combination now of pembro-ram in the second line setting, looking at patients that have had prior immunotherapy.
Awesome. That was such a comprehensive update to the trials that were talked about in the activity. So you touched upon some of the ongoing trials. So what are the developments that you're most looking forward to coming year?
Yeah, definitely. I think there's a lot of ongoing trials. The second line and beyond space is a very rich field of active investigation, both including novel immunotherapy agents, but as well as adding other agents. So a lot of interest in seeing the readouts of some of the studies that are looking at PARP inhibitors in combination with immunotherapy. We have seen and talked about this in our presentation, the Sapphire study, which is randomized phase 3 trial combining sitravatinib with nivolumab versus docetaxel in previously treated patients. That randomized phase 3 study has completed accrual, and we're waiting for the readout as well. And certainly there's a lot of interest in continuing to improve on outcomes with ADCs, or antibody drug conjugates. That's a rich field of active investigation. These agents are not only being investigated in second line and beyond, but also being investigated in frontline in combination with immunotherapy. In addition, we're also combining immunotherapy with targeted agents. We're seeing, results of studies combining, for example, immunotherapy with KRAS inhibitors. A lot of interest in continuing to build upon the success both of immunotherapy as well as targeted therapy as well. There are multiple studies that are ongoing that would be too numerous to tell you about, but those are some of the interesting strategies that I think I'm looking forward to seeing read out in 2023 and beyond.
Awesome. Are you currently involved in any clinical trials or research that you'd like to highlight?
Yeah, definitely. I think doing research and doing clinical care are really what drives me to do what I do every day. And so some of the efforts that I'm working on with our multidisciplinary team at Emory include investigating, again, we're involved in these frontline trials looking at ADCs, so really looking at the combination of ADCs. We have the Tropion study. The Tropion study is now moving forward in the phase 3 setting. So Dato-DXd is a really interesting agent that is moving forward as a Trop-2 ADC now in the frontline setting. In addition, we also have some ISTs, or investigator-initiated trials, looking at combining immunotherapy, for example, with IL-2, looking at some biomarker endpoints. In addition, we have studies in the second line setting and beyond, looking at, for example, the combination of pembrolizumab, ramucirumab, and docetaxel. This is a single-arm phase 2 study that we're conducting at Emory. I also conduct studies in phase 2 and phase 3 in small cell lung cancer. Currently, we have also some interesting studies in that space as well, which we really didn't talk about in our presentation, but there's a lot of interest in combining immune checkpoint inhibitors with other agents to overcome resistance in small cell lung cancer. We also have another agent called lurbinectedin, which is approved in small cell. We have an investigator-initiated trial combining lurbinectedin with radiation. And so there's a lot of interesting efforts that are ongoing. I did conduct a study while I was at the University of Wisconsin, which was a randomized phase 3 study investigating tumor treating fields, which is delivered using a device. This is electric fields that interfere with mitosis and lead to immunogenic cell death as well. This study is a randomized phase 3 study called the LUNAR study that randomized patients to tumor treating fields in combination with immunotherapy or docetaxel versus the standard of care. And this study has recently had a press release demonstrating that this met the primary endpoint of overall survival. And so we'll be talking more about this at future meetings, and excited to present these results.
Great, those will all be so exciting to see. My last question is, do you have any strategies for balancing the efficacy of all of these novel immunotherapies with their potential toxicities?
So I think one of the ongoing challenges of treating patients with advanced non-small cell lung cancer continue to be biomarker selection. I think PD-L1 is our main biomarker. We do need better biomarkers to really tease out, should we be using monotherapy? Should we be using combination strategies? We're looking at now studies trying to really hone in on the impact of, for example, STK11, KEAP1, and co-mutations in immunotherapy resistance. And I think one important way to balance out, toxicities and benefits is really identifying which patient needs combination strategies. So with biomarker selection. So I think future trials should continue to look at that, because monotherapy for sure is certainly, very well tolerated and is associated with, excellent quality of life and efficacy if we can really hone in beyond PD-L1, who are the patients that are most likely to derive benefit versus who really needs, the combination strategy of a quadruplet regimen, such as what we saw in Checkmate 9LA or now the Poseidon or, Empower 150, where you're combining 4 drugs for a patient with advanced non-small cell lung cancer who may have multiple comorbidities and is struggling with symptoms from their disease. So I think biomarkers is definitely a big one. The other thing I think is very important is monitoring. While patients are receiving frontline therapy with immunotherapy or immunotherapy combinations, it's really important to educate the patient and their family members in terms of potential for side effects and immune-related adverse events that they can occur at any time, even after you discontinue therapy. So educating patients on when to call, not to wait, and to have sort of check-in methods with the patient to make sure that we're recognizing these immune-related adverse events early is really important and crucial in allowing patients to continue on their therapies if they're benefiting from them and avoiding, escalation of these side effects to more severe side effects. The third key point, I think, is really working as a multi-D team and getting specialists in early to give their opinions and to help manage some of these immune-related adverse events. So working with pulmonary and pneumonitis, working with GI and colitis, derm, with skin toxicities and so on. So increasingly, I think other specialists getting involved early in the management of our patients when they develop these immune-related adverse events, I think is also really important.
That's really great advice. And this was such a really comprehensive update. So thank you so much for sharing all these exciting advances today.